Thanks everyone for joining. And thanks also for Ross and other colleagues in the ICB and the practices for just helping us bring the session together. We know it's really busy. It's never not busy in general practice. So really great to get an hour of your time. Just in terms of housekeeping, really happy cameras on or off, whatever really you prefer, recognising it's lunchtime as well. So if you're grabbing a sandwich, no problem at all. As Paul said, we are recording this and we will send you a link following this meeting together with the slides as well. So if you're a bit like me and the ability to retain information is a little bit limited, you can come back to this at any point and also share with colleagues if they weren't able to make it today. And just by way of quick introductions, I am joined today by Simon. If you give us a wave, Simon from Develop Consulting. So we both work in the healthcare sector of Develop and have been involved in practice level support and primary care support for many, many years. So hopefully we can give you a bit of a history and really what I'm hoping you come away with is a really good feel for what this programme kind of delivers, the impact it has, but also what it feels like in reality if you feel like this is something you might want to participate in. Some of you might know the programme well, may have participated previously. We have evolved the offer this year with NHS England, and there is much more flexibility in how we work with practices. So the starting point is really kind of what matters to you in your practice rather than everybody having to kind of go through the same practice. So I'm deliberately going to keep my bit relatively short because the most useful part I think you'll find today is directly hearing from the fantastic Rebecca and Claire, who are practice managers who have recently participated in the programme. And my brief to them was like, just give people a real warts and all of what this actually feels like, what was kind of challenging, what works well, and most importantly, what difference does it make? So we're going to sort of rattle through a few slides. We'll leave, I hope, plenty of time at the end for questions, but do use the chat or the Q&A function as well, and we'll try and pick any questions up as we go, but also put your hand up if you need to come on camera, whichever is easiest for you guys. So just very briefly, before we get into the kind of the as is and the programme as it stands today, I kind of just wanted to give you a bit of history because practice level support isn't a new programme. It's actually evolved over almost 20 years of improvement work across the NHS. And the roots go right back to 2007. Those of you who've been around long enough might have come across the Productive series where lean improvement methodology that has its roots essentially in manufacturing was adapted for healthcare. And that started in areas like the productive ward and then expanded into community services, mental health, and ultimately general practice. And Develop Consulting was involved in that work from the early days, including the development of the Productive General Practice Programme, which launched around 2011. And that was really taking kind of practical improvement methodology and put it directly into the hands of practice teams. And since then, the programme, as you can kind of see, has really continued to evolve alongside how the challenges in general practice have obviously continued to evolve. We moved through Time for Care, which introduced more targeted improvement support and structured facilitation. And then came the Access Improvement Programme, so much more focus on things like access, workforce, technology, care navigation, same-day demand. And then COVID hit, and obviously the programme evolved again through the Accelerate programme. So that was really responding to some of the really difficult challenges practices were facing around telephony, digital access, demand and capacity, and also that patient looping and unwanted variation that has become really kind of a big pillar today. And then from 2023, many of you might recognise the General Practice Improvement Programme, GPIP, as we sometimes refer to it, and Practice Level Support, or PLS, which I will probably refer to as we go through. And that really kind of was intended to broaden the focus further into modern general practice. And I know that phrase in itself can sometimes be like kryptonite for a lot of the practices that we work with. But essentially, this is about continuing development in your journey, on your terms and with your ambition. and really kind of looking at that sort of broader population health, wider practice improvement. So I guess, although the name has changed over the years, there's a really kind of strong golden thread of running all the way through. And that's really kind of, it's a program that is about understanding what is creating pressure in your practice and using data and improvement methodologies to kind of really get underneath the problem, and then work alongside your team to make those practical changes that release time, release capacity, and improve care for our patients. And that's really important in terms of our involvement as Develop Consulting. We're not a new provider picking up practice level support this year. We've been involved in developing and delivering these approaches through lots of iterations with NHS England for well over a decade. And members of our team, including Simon, who you've seen on the call, have worked with thousands of practice nationally. So in this year, the programme is evolving again. So we've still absolutely got that core practice level support offer, but there's much more flexibility in how that support is tailored. There is also a new Collaborate offer, and I know we've got some sort of PCN leads on the call, so I will dig into a little bit that in a bit more detail later on in the presentation. I wanted to give you a little bit of information of kind of where we're at specifically in terms of Humber and North Yorkshire and across the sort of footprint, the ICB footprint. So since April 23, we've supported around 90-ish practices. That equates to over 1,000 on-site visits and over 3,000 hours of support. So in Humber and North Yorkshire, we've specifically supported 20 practices. So the 93 is across the whole of the region. And the reason I kind of wanted to show you this isn't about necessarily the numbers. It's, I guess, to demonstrate that the support is really grounded in practical experience of working alongside and in general practice. Lots of the facilitators that support this work have a primary care general practice background. So those facilitators that are working with you, they understand the landscape. They know the reality of trying to improve something whilst simultaneously running a practice, dealing with demand, workforce pressures, contractual requirements, and everything else that lands on your desk. We're also working really closely with the ICB and regions, so the support complements what already is available rather than duplicate it. So the key emphasis really is hands-on support. So it's not somebody landing in your practice, writing a report and disappearing. It's about working with practices and PCNs and really leaving the team with skills and insights that allows them to really sustain improvement long after the support is finished. So I just wanted to dig into some of the specifics across Humber and North Yorkshire that we've seen over the last couple of years in terms of the support that's been provided. There's a lot of words on here, and again, I will send these slides out afterwards so that you can kind of read it at your leisure, but I'll just sort of touch on the headlines. So as you can see, there's really 6 broad themes that we've seen over the last couple of years that typically practices have really honed in on in terms of this support. So demand and capacity is obviously a really big one, and that is can be looking at appointment systems, it can be looking at prescription processes, it can be looking at workflows, and essentially what we're trying to ascertain there is where avoidable demand is being demonstrated. So it's that whole flow of how patients are accessing the practice and the demand that is being created and generated through that, and how that flows essentially through the practice. Claire and Rebecca will talk about some of the areas that they focused on, but that's definitely a very, very common theme with the majority of the practices that we work with, and probably, you know, at the core of what is driving people to want to participate in the programme. I think workforce effectiveness is also a really big theme that we see, and primarily focus on whether work is reaching the right person. So are GPs doing things that someone else could safely and appropriately manage? Are we making the best use of the whole practice team and the whole multidisciplinary team? So lots of work that we've supported in that space. And then patient access obviously links to demand and capacity, but it's not, as we see, necessarily about creating more appointments. It's about getting patients to the right person or the service as efficiently as possible. We've also seen practices focus really heavily on continuity of care, because improving access shouldn't mean losing continuity, where obviously that really matters. We also see a lot of work around collaboration and team engagement, and I think we'll see more of that through the Collaborate model this year. And we know that sustainable improvement it's embedded best when the whole team is taken on that journey. It's not simply a practice manager or a GP partner kind of singly driving this forward. It works when people actually doing the work understand the problem and help design and drive forward the solution. So lots of work on that kind of cultural element around improvement, which is so important. And then finally, data. So this is one of the things our facilitators help practices really kind of get under the bonnet of, and we find we work with practices on all ends of the spectrum here. Some that are really very used to using data, and others that are still grappling with getting their hands around the various data sets and how they really kind of get to grips with the cohort. And I think what our facilitators help practices do is really move away from, okay, we know our practices, and we know our population really well, and we think we know the problem, but the data often really helps, I guess, provide robust evidence to understand what is actually happening through the data and through the process mapping and through the measurement. I think the key point with all of this is we don't arrive with a predetermined improvement project. You'll all have different priorities. They might be prescriptions, they might be total triage, they might be care navigation, online consultation, it could be workforce, or something completely different. So the key thing is we start with your challenges. So wanted to have just a quick look at some of the impacts, but again, Claire and Rebecca will talk through what they've seen firsthand in terms of their practices and the impact it's had. So this is data that is provided by the national team, so verified, and lots of statisticians, I guess, sort of working on this. And it really helps us, I guess, make the case for support going forward. The landscape of primary care continues to change and evolve. There's more and more landing in that primary care sort of lap, and some of this data that we're collecting really kind of helps sort of demonstrate the impact of the programme. So these are based on actual improvements achieved by practices in Humber and North Yorkshire. And we know, so the programme, we hope, fingers crossed, will be subject to funding via the region, but it does require investment in time by the practice. So it does require for key practice individuals to be available, and I'll talk a little bit more about that in a second. But in the last couple of years, and what I'm hoping this demonstrates is kind of the return on investment that the practices might get through investment of that time. And in the last couple of years, as I said, around about 20 Humber and North Yorkshire practices. And what I'm trying to kind of demonstrate here is some of those practical results. So one of the practices did great work around their repeat prescription calls, reduced those by about 39%. So at the start of the programme, they had over 1,000 prescription calls, reduced that to 642. So, and I think also what we see is that continues to fall. So long after we've left, these improvements are sustained, and the practice still, doesn't stand still, is able to keep moving things forward. Another piece of work that we supported around total triage projected appointment-related calls falling from around 300 to about 75 a day. So again, some significant impacts. Not every practice is in that space of total triage, but it's those incremental improvements that we see make quite a big difference. Also, quite a lot of work we do across practices around appropriate appointments. So looking at where we can help practices understand how those appointments can be redirected into more appropriate pathways. And that can have quite a big impact, both on patients, but also particularly on clinical time as well. We also do quite a big focus around admin capacity. So we see through some of the work we do, again, around be around proactive prescription reviews, back office processes. We can significantly reduce some of the essentially hours of time that are spent on unnecessary phone calls, appointments, repetitive admin work. So it's about kind of creating that headspace to be able to work differently. So these aren't theoretical productivity calculations. They are they come from teams looking at their own processes and really kind of asking, why are we doing this? Is there a better way? And can we measure whether the change actually works? And again, you'll hear some more tangible examples of that from Rebecca and Claire. So last slide from me. I'm noting there's some things in the chat, so I'll come on to those when I hand over to Rebecca and Claire. I just want to give you, I guess, a bit of an overview of what it actually feels like from a practice perspective, if you are interested in joining the programme, and to give you a bit of an overview of the sort of type of support that's available. So as I mentioned earlier, the biggest sort of the thing that we're really excited about is flexibility. So historically, this has been a nationally funded programme, but now that sort of funding is moving much more into the system space. We have much more flexibility to work with the region, the ICB, and you guys to structure this programme of support depending on where you are. So we're not expecting every practice to follow the same journey, and the support is really designed to meet you where you are and focus on the things that really matter to you. So there are three main routes into practice level support. So the first is modern general practice, PLS. So this is really for practices that want to support, that really kind of what I guess want to develop or strengthen elements of modern general practice. So it could be access, could be care navigation, could be the demand and capacity, workforce, digital processes, AI, or kind of some of the underlying systems within the practice. So it's an offer that's really suitable for quite a broad spectrum of practices, and really is designed to, again, sort of tackle the solution that is the one that's sort of most prevalent in your practice. The second route is modern general practice advanced. So this is really designed for practices that have already made really good progress, might have done the programme before, but they want to sustain that or move into something that's more ambitious or more complex. So it could be planned care, could be total triage if they've not gone there, or it could be continuity, or it could be another more complex improvement priority. So it's designed for practices that have maybe already done a fair amount of improvement work and are really just kind of wanting to go to that next step. The third route is practice level support collaborate. So I will come back to that in a bit more detail after we've heard from Claire and Rebecca, but essentially this is where practices want to work together around a common challenge. So it could be a PCN, an at-scale provider, GP Federation, and it's really been designed with kind of, I guess, one eye on the developing neighbourhood models and sort of ensuring that we can best support primary care, either to further embed neighbourhood working, or to move towards and be ready for neighbourhood working. The other piece at the bottom, the D that you see, is the support level framework. So this is a very, very short sort of diagnostic offer that can be used as a complementary element to any of the three above or standalone. So this is typically 2 on-site visits, where it can be really useful for a practice that kind of knows things aren't quite where they want them to be, but perhaps aren't really sure where to start or what sort of support would be most useful. So the facilitator kind of works through a bit of a framework with the practice, builds a bit of a structured picture of where the practice is now, what's working well, where the pressures are, and where there might be opportunities for improvement. And at the end of those 2 visits, you might decide, that's given us what we need, we can take this forward ourselves, that's fine. Or you might identify areas where one of the 3 broader PLS routes would add value. Okay, so just want to come on to the diagram on the right, just to finish my piece off, just to try and give you a bit of an articulation of a typical practice journey. But again, just reminding people that there is no typical practice journey. It's very much an individual journey and sort of leaning into where you are. But if you come into any one of those three main routes, you'll typically join in a small cohort of practices. So it can be normally anything between 4 practices and 8 practices. And these could be practices from across the whole of the ICB footprint, or particularly with the collaborate route, it could be practices within the same PCN or group or federation group, however you kind of really want to work. So the reason we really work in cohorts is obviously the improvement work is very specific to your practice, particularly with NGP, PLS and advanced. It is a very much a one-on-one practice journey. But what we want to ensure is that there is an opportunity for peer learning, because what we often find is that practices are grappling with very, very similar challenges. So the cohort gives you an opportunity to share experience and learn from each other. So if you do decide to join the programme, your first session, if you like, would be kicked off with an initial group-based learning session. And that's an opportunity to meet the other practices in your cohort, particularly if it's the NGP, PLS or advanced. Obviously, if you're entering as collaborate, you'll be entering as a PCN. So we'd hope that you'd all know each other. But there's an opportunity essentially come together. And what you're sort of understanding in those sessions is everybody else's ambitions, sort of the challenges that you want to focus on. And it's an opportunity also for us to kind of get into a little bit more detail about how the programme will work. And then from there, you will actually be allocated your own dedicated facilitator that will work with you for the entirety of your journey. And that's really important because you're building a relationship with somebody who gets to know your practice, your team, and what you're trying to achieve. And that is really consistent all through the visits that you receive. And then typically in the first few visits that we spend with a practice, and this is on site, so we come into practice every week for half a day, 3.5-ish hours. And what we're really trying to understand in those first few visits is really getting under the bonnet. We're kind of looking at your data, we're looking at your progress towards modern general practice, we're understanding your ambition. We'll spend time with the wider team to sort of understand how are things actually working day to day? So where is the demand coming from? What are the pressure points? Are patients really reaching the right person the first time? Where might staff be spending most time on processes that are adding value? Where are the patients having to contact you repeatedly? And where might we be creating avoidable or failure demand? So we'll spend normally 2 to 3 visits. Sometimes it's quicker, sometimes it's longer. Really sort of depends on where you are. But what we're truly sort of also trying to understand is what's working really well that we can build on. And so for some practices, that diagnostic work can happen quite quickly because you already know exactly what you want to tackle. But for others, we might spend several visits really understanding what's driving the pressure before deciding where to focus, and that's absolutely fine. I guess the key thing here is we diagnose before we prescribe. So what does an individual visit actually kind of look like? So typically an on-site visit is around half a day, and we will agree a regular rhythm with you and a day and a slot that typically works. So if you have a sort of slot on a Tuesday morning that works generally well, we'll try and keep to that Tuesday morning. So we agree that with you ahead of your sort of sign up. Doesn't mean that your whole practice team is sitting in the room with us for half a day every week. What we need is a key practice contact, ideally somebody who can act as your improvement lead, coordinate the work. It's also really great to get clinical sponsorship and clinical buy-in because sustainable change is very difficult without that. But your GP and clinical lead doesn't need to sit with us for 3.5 hours every time we visit. But for each visit, it could be really different. We want to focus on what we're trying to achieve, who needs to be involved, and who are the people that can really help us move that particular piece of work forward. So one week that might be practice manager, the next week it might be the reception team, the third week it might be both, another week it might be a GP, a pharmacist, or a care navigator. So it can really kind of depend and flex and evolve, and we will be flexible to respond to capacity as well. So it's just really about the right people in the room at the right time, rather than taking your whole team away from the day job. There is a commitment from the practice, and we want to be really transparent about this. So even the financial cost of the support, we hope, is funded. There is still an investment, as I said, of practice time. And it's not the role of the facility to do to you and come in and do improvement. It's for your practice to come on a journey with that facilitator, and everybody else kind of just carries on their day job. It works best when practices really actively engage with it. But the whole point, obviously, investing that time is to create headspace and capacity further down the line. And we want you to come out of that session feeling like you've really tangibly moved something forward. So what we see in practices is after even session 2, they might kind of have a much better understanding of why a particular problem keeps happening. They might have redesigned a process. You might have tested a new way of working. You might see an improvement in your data, and you will hear in a minute the reality of kind of what that actually feels like. So once we understand those issues, we work with you to develop your improvement plan. And the word "your" is really important. So we're not arriving with a predetermined list of things that we think you need to change. We'll bring our experience of working with obviously thousands of practices, and quite often we'll have seen similar challenges. So we can bring ideas and tools and examples of what's worked elsewhere. And where useful, we sometimes connect you with other practices that have had really similar things to work through. But ultimately, it's your practice, it's your priorities, and it's your improvement plan. And then once we have that plan, we'll typically bring the cohort back together for another group-based session. And there's an opportunity to reflect on what you've discovered, share your priorities, learn from what your peers are doing. And that sometimes generates ideas. You might want to refresh your plan on the back of that. You might feel like, actually, great, no, we're happy with that. But sometimes we find people are working on really similar issues, and other times it can be really, really different. So all of those are kind of really valid. And then once we have that plan, we get into that kind of testing and implementing change. So that is this next stage is where we really start to drive the improvement work forward. And we'll work with you to test changes, measure what happens, learn from it, refine, test again. So we do structure, obviously, this quality improvement around things like plan, do, study, act, but you don't need to come into the programme as a quality improvement expert. That's what we're here. That's what we're here for. And we're not going to ignore there is, an obvious quick win, because as you can see from this diagram, even in this sort of just after this group-based learning 2, we still may not have reached implementation. And if we uncover something during those first couple of visits that we can improve straight away, we'll start working on it. So the important thing is that you see tangible movement and measurable improvement. That's that sort of ability to very quickly sort of come up with the innovation and be able to implement it is what we see time and time again. So the support will typically last anything between sort of 9 and 15 weeks. You might go through, you might actually get to visit 6 and go, wow, we've actually really rapidly moved forward, and we're actually fine. We've done enough. We're happy to go it alone. You might want to keep going right up to the 15 visits. So again, once you express an interest in this programme, we can work with you about what level of support is relevant for your practice. I'm just trying to think what else I might need to I guess the key thing with this whole programme is it's not just about the support for the 6, 9, 15 weeks. It is a key priority for us as a delivery partner is to leave you in a stronger position than when we arrived. So yes, there will be tangible improvements, but also we want to make sure that we leave you with the skills and confidence to continue after we've gone. So that's what we wanted to get Claire and Rebecca to talk about today. So I'm going to hand over, I think, initially to Claire. There's just some comments from some of the practices we work with. I'll let you read those at your leisure. But I think let's get into our initial feedback from Claire, and then we'll head over to Rebecca. And do keep putting any questions in the chat. And yeah, Claire, over to you.
Hi everyone, so I hope you can hear me okay. I was having problems with my microphone yesterday. Just a bit about me. So I'm Claire Collins. I'm the practice manager at North House Surgery, which is based in Ripon. My background, I worked in secondary care for 5 years before I started this role last year. And before that, I was a nursery manager. So I did joke with Sue and Rebecca a couple of weeks ago that I swapped Ofsted for CQC. Just a glutton for punishment, I think. So the reason that I applied for the practice level support was North House Surgery is actually the first GP practice for Harrogate Hospital to buy and take over. So it was a really massive event that happened within the PCN, and my first day at the practice was the first day that the trust took over. So it was definitely a baptism of fire. And the reason the trust put someone in post here was the existing practice manager was retiring, and just given all the processes and changes, etc., it just made the most logical sense. However, it was really difficult to learn about primary care in such a short space of time. So when I heard about PLS, the practice level support, and modern general practice, I just applied straight away, had to grab it with both hands. And it's not to speak badly about the practice at all, because they're wonderful. I fall in love with everyone here, but it was really evident that a lot of good practice and quality improvement had just fallen by the wayside a bit. I think sometimes things can get a bit comfortable and maybe not challenged as much. So it really gave me an opportunity just to be able to come in, but also step back, listen to what everybody was needing and wanting, and be guided by an expert. So my consultant was Alan Cresswell, and he was amazing. I mean, just wow. I don't know what I would have done without him, to be honest. I have been married for 20 years. I didn't fall in love with it, but he was amazing. He just came in. I was really nervous, actually. I was nervous for this expert and consultant to come in, and I was worried that he would judge me for being a new practice manager and not knowing what I needed to know to implement the changes straight away. I felt as though he would come in and expect me to know everything, and he was just the complete opposite. He straight away picked up that I would need extra support, and he gave me all the tools and resources that I needed over the time. We had dedicated days, which were Thursdays. I made sure that I was the lead contact, and here at North House we have a tri-leadership model. So it was myself, the GP clinical lead, and the nursing manager, and between us we protected our time just to make sure we covered all the bits and bobs that we needed. And then each week we would, as Sue said, involve the reception team in the improvement plans that we needed. Then we would speak to dispensary if needed, etc. It was really great, and the way he was with everyone, he was just so friendly and approachable. Everybody just loved him, so the clinicians just opened up to him. The reception team didn't feel judged at all about bits and bobs, because sometimes that can happen, can't it? I feel like reception really get the brunt of I can't even think of the word, patient perspective, receptionists, they just stop us doing anything. So he was just amazing. Yeah, so that's why I decided to apply, and I'm really glad I did. So over the course of time, I mean, though there's probably a lot of things that we identified in the first few sessions, but Alan was really great at saying, look, let's just pick 3 things that we can really focus on, and he did that really good, almost impact style quality improvement model, because there's only so many house fires you can put out at any one time, otherwise you're going to run out of water. And he was great. So we focused on team communication. That was a really big thing, actually. And I don't know if other practices find this, but a lot of the staff were part-time, so we would find maybe information didn't get passed on as well as it should have. There were no practice meetings, really. There wasn't any of that good quality work going on in the background. So yeah, that was definitely something we identified. Skills matrix as well. It was really handy for me to be new, because I said it was a great way for me to say, oh, you know, whilst I'm new, maybe we should do a skills matrix because then I can learn more about what people do. And actually, by doing that, it meant new starters in reception could be assessed and given the support they needed. And you'll find as well in your practices, you've probably got people that have worked there for decades and they just know everything. But that doesn't mean everybody does, especially new starters. So having a skills matrix was really great, and also really outlining what our clinical staff can do, and just bits like that, you know, what people know in their head, not everybody knows. So we made everything really transparent and clear. That was amazing. And the biggest thing I'm sure everybody struggled with was appointment demand. So when I first came, the model was everybody has to ring at 8 o'clock in the morning, otherwise you won't get an appointment. Just that classic 8 a.m. scramble that I'm sure is just consistent across primary care. I think, you know, we have 9,000 patients and I think we received about 3 consults a week. The rest was all on the telephone. It was just baffling, actually. GPs were having 10-minute appointments. Just one GP all day, every day would be triaging all these patients. It was just, yeah, it was really mind-blowing, actually, considering I'd come from planned and surgical care as well, which was very, very organised in a sense. So Alan gave me a really great example. He said, right, Claire, just visualise, you know McDonald's, don't you? I said, yes, Alan, I do know McDonald's. He said, well, back in the day, everyone would go to the drive-through, wouldn't they? Everyone was at the drive-through in the queues, it was massive. And then they implemented the NHS, the McDonald's app. I said, right. He said, and that just transformed everything, didn't he? Because now McDonald's know what their customers want. They're ordering from home and then they're pulling up and they can organise everything in advance. And that's what e-consultation does. You can ask patients just to contact you from home. They don't need to be ringing up on the phone. Then you know you can plan the appropriate. I said, wow, that's just absolutely blown my mind. And when he then sat with the GPs and explained that, and reception, they were all just blown away. Just something as simple as that. It was just amazing. So yes, that was the big thing, appointment demand. And then the outcomes were, for the first one, for team communication, just complete team morale just instantly changed. So because we're part of a trust, we do a quarterly staff survey. The staff survey results at the beginning were quite low, you know, staff were feeling quite isolated, quite overworked, not in the loop with relevant updates and processes. That's all completely transparent. I'm so sorry I've not had a chance to pull more data. It's just been a week. It's been a week. So yeah, just by the survey results, that's something I could demonstrate to CQC just how our staff are feeling so much more supported, and they've thanked us for even just receiving minutes, I think, or actions, just, you know, being cited on conversations that are happening is so important to the staff. That's something that was definitely overlooked here. And then just confidence and team abilities, I think, especially for new starters, and especially for the reception team, I think for them to be able to complete a skills matrix and think, oh, I'm actually competent. You know, I'm as skilled as Barbara, who's worked here for 20 years, but I've only been here for 2 months. That's massive. That's just impacted them so much. Just little things as well that Alan introduced for, you know, do all your reception team know how to utilise pharmacy first? Just things like that, you know, and it was like, oh, I don't know actually. And have you got printouts of that? He provided us with all that information. It was just that was amazing, which then also impacted our appointment demand. And so we completely transformed, we relaunched a new appointment system. We haven't gone total triage. We're following the we just don't feel the demographic in Ripon are quite ready for that. And that's something we also listen to our patients. We have a patient participation group that we started because of Alan as well, which was really good, because that had fallen by the wayside since COVID. And they have said they would like it to be, you know, digital, but also still telephone if needed, and also face-to-face, which, you know, we can accommodate that here. But so we introduced an acute care hub, and rather than having a GP just sat alone in his room all day ringing what probably felt like 1 million patients, we now have a GP, an advanced nurse practitioner and a receptionist all sat together. and that's our hub, and they deal with all of the things that are coming in on the day. They review all of our e-consultations. We changed our appointment slots, so we do still have some same day on the day appointments. We have some 48 hours, and the rest are either within a week or pre-bookable routines. And at the time, routines were about 5 to 6 weeks. We've now managed to bring that back to 3 weeks, and we want to continue improving if it's needed. I mean, routine is routine, isn't it? Primary care was never designed to be an A&E on the day, and I think COVID really impacted that, and the Amazon Prime mentality of patients. Sometimes they just have to be reminded that they're coming to see their GP. They don't need to be seen on the day. So we've done a lot of patient education sharing about the new appointment system and the acute care hub, so they understand, and patients have been really receptive to it. It's been amazing. Also, I genuinely think improvements-wise, I don't have the data, I'm so sorry. So we've had fewer calls into the practice. So just May's data, we've gone through that with the reception team. We had 1,000 less calls for the month, year on year. They've noticed the effect on them and how they can get on with other key tasks, rather than just answering the phone constantly and battling with patients, telling them to ring back tomorrow at 8 o'clock in the morning. You already know then it's going to be a bad day tomorrow, because I've just had to tell 100 patients to ring back tomorrow. Also, the GP patient survey results for 2026 have just been released a couple of weeks ago. We scored 92% good overall, which is a 10% increase on last year. And I genuinely believe it was practice level support's help that made that happen, considering we were taken over by a trust. It could have gone either way, couldn't it? It was so new. It could have been taken really badly. I think the investment of quality improvement has really driven that. And yeah, I would just really encourage practice managers, GP partners, whoever's representing their practice, to just apply and do it and commit the time, because it's amazing. I would do it again if I knew I wasn't stealing someone's slot, because there's always an improvement project that can be going on, and something that can be driven. Yeah, I would really encourage people to take part. Thank you.
Brilliant. Thank you so much, Claire. I've got loads of questions, but I'm really mindful of time. So do stick stuff in the chat. I'm hoping people can access the chat, but do stick stuff in the chat. There'll be emails afterwards as well if you've got any follow-up questions. But clearly some really significant impacts there, not just around patients, but also around the team and how the whole practice works. So that's been absolutely amazing to hear. So yeah, by all means, put an expression of interest in, like if we can always put it in the pot. So I'll come on to that in a second. Right, Rebecca, over to you. Do you want to give us a little bit of insight into Brooke?
Yes, so I had just taken over as practice manager in the November. I had been here sort of 4 years prior to that, but I had a new assistant practice manager that was new to the practice. I had a new reception lead, and my management team were very new. So when I saw this come through from the ICB, I thought we'd take a chance and we'd invite somebody in, and hopefully, we'd be awarded a place, which we did. However, I was terrified, because you're inviting somebody in a quite formal, what feels like it's going to be quite a formal situation, into your practice to bear all to somebody that you've only just met 5 minutes before. And I was thinking, what are they going to think? Pam asked me to give her a call the night before she was coming down for the first time, and she was just, from the first minute I spoken to her, so warm and so lovely and so friendly, and I was just really excited to meet her the next day. She came down and introduced herself to the staff, and we got the ball rolling. So this is just one of the aspects that we looked at. There was a whole load of work that we did. For us, it was a very successful time that Pam was with us for GPIP, because it was GPIP Pam. But it was a very successful time. There was so much that we did, but I have just sort of narrowed it down to one of the areas, and I do have the data. So that was just sort of saying that as the relatively new team, that was the reason we signed up for it. So one of the initial areas that we did identify was that we were receiving 400 voicemails a day just for prescription requests. My data quality admin team were the team that were working on these, and what we found that was taking the time for these was that it was incorrect prescriptions that were incorrect medications that were being requested, incorrect doses. People were trying to request a change of dose via this voicemail line, and it was taking so much time for then our admin staff to recontact patients to ask, did you actually mean this medication? Or if you want in a medication review, you're going to have to book an appointment. And it was just huge, and it was quite unmanageable for the team. It was causing a lot of stress because it's sort of, people want to know that they're going to have the medications, you know, within that 3 days, and it was putting a lot of pressure on the team. So that was the first area we decided to work on. So our action plan, when we sat down to look at it, we looked at the process of how the prescription requests came in, because not only did they come in on voicemail, they came in on email, they came in at the front desk, they came in via our online method. So voicemails was just actually one aspect of it. So we looked at the whole ordering process all together and looked at where we could look at those efficiencies and think about the patient safety aspect as well. So what we wanted to do is we wanted to engage with our PPG. We do have a strong PPG and we're very lucky. We thought about how we're going to communicate the changes we wanted to implement to both staff and the patients, so everybody was aware, and then monitor the impact. So that was the action plan that we had to work from. And so yeah, sorry, I'm looking at my slides and also looking at the time. We reduced our administrative work by 13 hours and 14 minutes each week. And how we did that was that we removed the voicemail line. So on my next slide, I'm going to show you the planning that went into starting this process in June and then to the 1st of September when we actually turned the voicemail off. So this was all of the background work that went into it. Sorry, it's not come up as well. And what I want to sort of express as well is that Pam was here for every step of this, and we looked at it. It wasn't just giving you an idea and saying, right, go crack on with it and let me know how it goes next week when I come back. We sat down and we looked at every single step and every aspect of what we needed to do to make this successful. So we had, you know, a text message that we repeatedly sent to patients throughout August saying, be aware that from the 1st of September, big changes are happening. This is how you are going to be able to request your prescriptions moving forward. We did let our PPG know throughout August. They came in throughout July and August. They came in and they were promoting the NHS app for patients, because we were promoting NHS app and online for requesting, no voicemail. We made sure that we contacted all of our vulnerable housebound patients directly to ensure that they felt that this was safe for them and they weren't being left behind. We made campaigns on Facebook. We improved our website information about how, you know, how soon you could order your prescription, the waiting times. We discussed ERD with patients, which is a lot of electronic repeat dispensing. So if there's people that are on medications and they've been on them for a while and they're, you know, safe to take them regularly, that can be dispensed to the pharmacist so that it just dropped down every month and the patient doesn't actually have to request it. QR codes, just there's so much there that I'm sure you can see that went into one aspect, and it was brilliant. You know, our receptionists got on board with it, our GPs and nursing team staff got on board with it, and we're explaining it to patients in the consultations. It was just a really positive piece of work that we did, and like I say, we had 40 patients added onto ERD just in that time period alone, where usually it's about maybe 10, 15, but we reviewed and we have a lot more people now asking to be considered for it because of the amount of information we've given about it. It doesn't, you know, when people hear acronyms, they're not sure what it is. But now that people are aware of what electronic repeat dispensing is. And finally, just the impact of it. Voicemail was removed. Like I said, 13 hours and 14 minutes of administrative time a week. There was fewer related telephone calls asking, you know, if the gentleman really wanted the morning after pill or if he just misspoke on the phone. Staff released to support patients with more complex needs, you know, and there was no significant increase in complaints. The biggest area that we had patient feedback, pushback about this was on Facebook, and it was all about, you know, vulnerable patients. And when we explained what we were doing for vulnerable patients, we didn't really have any pushback at all. And I think it was because of the level of detail we'd gone into the planning with Pam and the confidence that we felt that we were able to dress our patients with that was really, really helpful. So that was one of our experiences.
Amazing. Thank you so much, Rebecca, and thanks, Claire, as well. I think you can sort of see some just really tangible improvements, but also I think what's striking is how you've engaged that kind of whole team and sort of taken them on a journey. Amazing. Thank you so much. I'm really keen to try and just allow a little bit of time for questions. So I've just got one more slide to go through. So what sort of Claire and Rebecca have just described is very much that kind of one-to-one practice journey. But new for this year is, as I mentioned earlier, the PLS Collaborate. So this is that third route into the programme. I just wanted to spend like a minute explaining that in a bit more detail. So particularly for those of you that might be joining today from a primary care network or working across a group of practices. And I guess the simplest way to think about Collaborate is that it takes all the same practical improvement approach that we've been talking about, but it just asks, what are the things that would be better tackled together rather than practice by practice? So that might mean working as a PCN. It could be a group of practices, as I said, within an at-scale provider, or increasingly what we're seeing is how general practice can work together as part of an emerging neighbourhood model. And that's really relevant. We know at the moment the general direction of travel for the NHS is increasingly towards that sort of neighbourhood and populations rather than individual organisations. And obviously, primary care is so pivotal to that model as the anchor. So we know practices are being asked to think about modern general practice, new models of access, population health, greater integration. And potentially on the horizon, we've also got new contractual models around single neighbourhood provider, multi-neighbourhood provider. So there's lots of detail still to emerge around that. I guess this particular route really kind of helps kind of those groups of practices to think about what the underlying capabilities are required to make neighbourhood working successful. And those are things that we can start building now. So, you know, are the practices across your PCN working effectively together? Do you understand variation across practices? Is there a common improvement priority? How do you use your collective workforce? Do you use population data to understand where the need is? So lots of you are already kind of doing lots of work in this space, but building those effective relationships both within your PCN, but obviously around the neighbourhood model with the wider community services, the secondary care, the local authorities, the voluntary sector, all around those wider determinants of health are key to this sort of route into the programme. So really the space that this offer is designed to support is starting with the problem, not the organisational structure. And just like the PLS offer, we don't arrive with a predetermined project. It's about what you're looking to achieve together, what's currently getting in the way, and how do you want to work sort of collectively towards that, addressing that shared problem. So again, if that's an area that you're interested in, we are going to put up a bit of an expression of interest as we send the slides out, so that if you're interested in learning more about that, then let us know. And then finally, just to sort of reiterate, if you've heard anything today that you think actually this could really help us, or I'd like to find out more, I'm going to pop a little link in the chat, and I will also email it to you all afterwards. There is an expression of interest form, and this is us just trying to understand a little bit more about your interests, the challenges that you want to address. And if you want a follow-up conversation, that's fine. The expression of interest doesn't commit you to participating, but given that there will be a limited amount of funding for this support, it's also will help us work with the ICB in the region to prioritise the practices. So I think that's it for me. A huge thank you to Claire and Rebecca for sharing your experiences so openly, and obviously to Paul and ICB and Vic for supporting this session. I think that leaves us 2 minutes. So apologies, not quite the amount of time I wanted to allow for questions. I have a feeling that some of you guys can't access the chat or put your hand up. So because everything's been slightly quieter than we would normally find on these sessions. So I have just played around with settings. I don't know if that's fixed it. So it might have felt like a bit of a one-way street today. But these emails, I will also, our emails, Simon and mine, I'm going to send you all an email afterwards. So do get in touch directly, give us a call, and I will pop the expression of interest form in as well. I'm going to pause there. I'm thinking there may not be any questions because actually nobody can unmute themselves or put their hand up. So that'll be a quality improvement for me next time. I might check the settings. So yeah, I am going to pause, but I have a feeling it might be quite quiet. While I'm pausing, Simon, is there anything I've missed, do you think, there?
No, I don't want to take up any time if people can get in. The only thing that I would say is just to reiterate right at the start, I think when we developed the programme, the initial programme, the Productives, I think it was one of the first national programmes that put frontline staff at the heart of improvement rather than be a top-down approach. And nobody knows the process within your practice better than the people on the ground. So, yeah, I just encourage anybody to at least show some interest in how the programme can support them.
Brilliant. Right, I'm going to leave it there because I am assuming you're all having, there's just some weird setting that's not allowing you. Oh, Lou is typing that actually we can get access to the chat. Brilliant. So we will send out the recording this afternoon along with the expression of interest. So if you are interested in participating, as I said, we're still working with Vic on finalising funding arrangements, but if we've got you know, information that you might be interested, that just helps us prioritise going forward. Again, just finally, in terms of, you know, if you are keen to sort of start, there's flexibility around when the support starts. So we typically are working around a 4 to 5 week lead time. So as soon as funding is agreed, I think we're probably the expectations that we'll be onboarding practices from September onwards. So we'll of course keep you in the loop as we learn more about funding, and if you've got any questions, do get in touch. But thanks everyone.